So I thought for this panel, I'd start asking some basic questions. And so if you could describe who was on your Section Q implementation team, who participated, and how did you get organized? So let me start with Dawn.
In Connecticut, we worked through the nursing home associations to identify nursing facilities that might like to partner with us. And from that, three facilities were identified. One of them wasn't able to participate because the Department of Public Health called a surprise inspection the first week. We won't go there. But anyway, so they decided not to. They declined to participate, although they're working with us now. And the other two facilities, one was a facility very eager to work with us. The facility administrator is here today and working in the workshops, Martha Dale, and she's also co-chair of the Money Follows the Person Steering Committee and has been involved ever since 2001 when the first round of Real Choice Systems Change grants were involved. The other one was a facility called Kindred Health. It's a chain in the state of Connecticut. They have facilities also in Massachusetts. Both of them participated, but we worked through the association to get that agreement.
Okay. Mark, in Texas, how did you get organized?
Yes, I want to say two things. One, I brought a handout. It's about 38 pages, and it covers information letters, how to work with relocation specialists within a nursing facility environment. It has assessment tools that relocation specialists use as they try to assess that individual. It has individual responsible agreements that works with individuals between the home health agency and the individual. There's a lot of information, plus the new re-procurement we're doing for our relocation contract. I'll give you a link if you want to look that up. I couldn't have a full thing for everybody. I brought about 50 of these, but I brought about 75 cover letters to get the information. And I want to thank the American Healthcare Association affiliate in Texas, the Texas Healthcare Association, for working with us. And in the state of Texas, I contacted Tim Graves, who is the executive director of the Texas Healthcare Association, in working with them in relationship with our relocation specialists, our managed care organizations, and our case workers. They were all part of this team. We selected 3 nursing facilities. That was through the Texas Healthcare Association. They asked for volunteers. I asked for when to be in an urban area, when to be in a suburban area, and when to be in a rural area, see if there's any sort of differentiation. We met and talked on an ongoing basis to ensure that they had any questions or the team was working as a team throughout that process.
Okay. Mary in New Jersey, how did you get organized?
We started a little bit before that. We met with our own administration. Oh. Can you hear me now?
Closer.
Okay.
Yes.
Here it works. I met with my administration and pulled in all the stakeholders on the state side, the ADRC, and touched base with DDD and MFP, and we talked about how we were going to do this. We already have a presence in the nursing homes with the Community Choice Initiative, which we've had out there since 1998, but we knew this was an expansion beyond the usually counseled Medicaid or potentially Medicaid eligible individuals. So we needed to figure out, and we weren't sure how many referrals we would get, who would be doing that. So we had to talk it out. Were we going to use ADRC staff? Did we have the financial resources? Did we have the staff resources to do this? And in the end, we decided it was a natural outgrowth of the counseling we're already doing in the nursing facilities. So we went that route. It did not require more funding. We just expanded the roles of the community choice options counselors. We then went on to meet with the New Jersey Hospital Association. Their long-term care unit worked with us, and the nursing home associations of for-profit and non-for-profits. We talked about the program. I took PowerPoints and all kinds of education materials about Section Q with me and talked it out. And they agreed to canvass the state for a candidate, and someone called me, lo and behold, the very next day, very eager to participate. went out and did the road show with, and talked about it. They wanted a few days to think about it and called me a few days later and said, yep, we're on. Went out and did the more intensive training, pulled Dan Milne in by teleconference so we could talk about it. Also went out to our long-term care field office, the local contact agency, talked about the processes, how were we going to make referrals, how were we going to track them. So after we had the initial meeting with the nursing home, we came back and talked about all the processes and how we were going to make this happen, and focused more on the paperwork, the tracking, and everything else. That's really how we got our foot in the door with the pilot.
Great. Ellen, how did you get organized?
What I did was we already have a robust transition program, so I selected 3 of the waiver agents that we work with under the transition program, and I too tried to get the urban, suburban, and rural. And you can tell I'm from Michigan because they were over here, here, and up here, so we had the whole state covered. And we asked them each to select a nursing facility in their area with whom they would like to work. And so, and I didn't choose our top performers because I wanted to see how this work played out with some of the less stellar performers. And so we just actually completed it a couple weeks ago. So.
Okay. All right. Well, the second toss-up question, I guess, is for each of you, how did you organize the collaboration between nursing facilities and the local contact agencies at the local level? And I guess, did these entities already have a working relationship prior to this? So we'll start with Dawn.
They did already have a working relationship, but as a beginning point for collaboration, going back to the first implementation of transition services, dedicated transition services in the state, we did require that the local entry points go and meet with the administrators of the nursing facilities, and before that we sent out a Medicaid letter to all nursing facilities, letting them know what was going to be, what kinds of services were going to be now available within that. So the first step was to contact from the Medicaid agency a letter to all nursing homes, and the second one was letting them know that they were going to be approached by the local entity about new services available, and the second was the accountability on the organization, the local level organization, to go and meet with that particular administrator and then report back to us that in fact it was done. So that was the beginning step for collaboration.
Okay. Ellen, same question.
I pretty much answered. They had the relationship before we started this because the waiver agents actually selected the nursing home that they worked with.
All right. Mark?
Well, the state of Texas, we have just relocated our 20,000th person. So we've had a long relationship between relocation contractors and nursing facilities. And so the question really was more selecting of the nursing facility. Once they selected the nursing facility, we pretty much told the relocation contractor, you're going to participate in the rest of the relationship.
I think Mary Sales from California is not here. She sent me her notes last night, so I'm sort of speaking from a California perspective. They chose the Aging Disability Resource Centers to do the Section Q transition coordination. And they learned a big lesson about that. And that was, in California, the ADRCs did not have a prior working relationship with nursing facilities. They'd been focusing on hospital discharges and so on and working there. And so this was sort of a new phenomenon for them. Their other lesson was they didn't really do any training about this, and as a matter of fact, we gave them a terribly short time period to get organized and started, and sort of skipped the training part. And the lesson was you really can't do this without sort of working on developing that collaborative relationship between nursing facilities and local contact agencies, and doing some training of that staff. And I think Mary Malik from New Jersey talked about sort of the several episodes and conversations and getting people together to do training. So one of the strong lessons from California was if you don't do sort of develop that collaborative relationship, if you don't do training, it's broken from the start. But they used a pilot test with 3 facilities instead of the hundreds and hundreds of facilities across the state to sort of work the bugs out for them. So it was an important lesson for all of us. Okay. My next question is basically a little bit about outcomes. Sort of how did the Section Q process work in your state? So we'll start with Mary.
We had over 200 interactions, MDS interactions, and we were very surprised that it only generated 5 referrals to the local contact agency. And we tried to analyze that a little bit. We weren't sure if, maybe the discharge planners weren't as enthusiastic as we were. Maybe they were matter of fact in asking the questions and not explaining, what a referral to a community agency might mean. Plus the fact that as a result of pre-admission screening, many of these individuals entering the nursing home already have been seen by the community choice counselors and have already had the options counseling presented to them. Something else we thought maybe, there's a little bit of distrust with individuals if they're going in subacute, and they ask them these questions. They don't want to divulge their financial information. They may feel like, I'm going home, I'm going to convalesce from this, I'm going home, I don't need any help, and I don't need to be talking to the government about what my income and assets are. So, there were some different things we thought it might have played into that. That was our only big surprise. It only generated that many. And, when we look at the statistics, the hospitals alone are discharging about 100,000 individuals a year to nursing homes in New Jersey. So it remains to be seen what's going to happen when we roll this out statewide. But we are going to use our existing resources, our existing staff to go in and do the counseling. And hopefully it won't overwhelm us too much. So.
Okay. Why don't we go down the row, Mark?
Well, it's amazing. Like I stated, we've relocated 20,000 people, and we too had generated not as many relocations from this process. And so I guess there's always some lessons to be learned here. Now, the state of Texas has a very stringent medical necessity. I don't know how the rest of your states define it. Ours is you need the intervention of a licensed nurse on a daily basis. So it's very stringent to get in the first place. And there's a high level of need. I personally think there's a number of issues going on. Even though we've had a system now for the last decade, there is turnover, and there still is, and I'm not saying this in a negative connotation, but there's still bias in the nursing facility staff that is the most safe environment for that individual. And even though they're asking the questions, I think there's a lot of work and education that needs to be done with the nursing facility staff, whoever's asking the questions, and looking for that response. Many of the people said, well, and a lot of people said they felt very uncomfortable asking the question, should somebody go home, when in fact they thought that person would never go home. And so we were setting up those false expectations. So that is a big problem there. I think another issue is when there's family intervention. The family finally got that person to finally go into that nursing facility, and here you are, the state, or there's a new process, really working hard to get that person back out of that facility. So again, I think there needs a lot of education that needs to be done, not only with the families, but also with the attending physicians. Attending physicians too have been a significant problem for us throughout all of our relocations. There's also with the home health agencies, again, depending on how your home health licensure rules work and how individuals have to take it in a person. Many feel there's a liability here. This whole issue about 24/7, a lot of mythology. We actually have a complex needs initiative going on to try to educate the home health agency. Part of that packet I talked about has an agreement there where you can sort of talk about those issues. So it's the combination of all those different little factors that we're learning about, and it's going to take, I think, a lot of education, a lot of training, and I hate to use a sort of psychobabble sort of term, but it really is a different mindset. And I think that's where we're trying to get at.
Okay. Don?
In the state of Connecticut, the nursing facilities did a great job of making sure that every person who entered the facility did receive the new Section Q. They completed 60 assessments over the 2-month period. Out of the 60 assessments, 75% of the folks who participated indicated that they had an expectation that they would return to the community, which is a fairly high number, and reflecting some concerns on the part of the administrators, because many of the folks who were responding that they had an expectation to return to the community, I think the social work staff at the nursing facilities wasn't sure that that was actually going to be a viable option. That raised some concerns that perhaps we'll address at a different point during this panel discussion. Out of the total number of people that they offered the Section Q to and asked the questions, 15% were referred to the local agencies. Now, one of the things that I learned when the very first set of reports came back, since 11 people at that point had been referred to the local agency, and Medicaid agency in our state is the entry point for that, and I hadn't gotten any of them, that kind of signified that there was a bit of a communication problem. And what was happening was the nursing home social workers were just normally using the home health agencies, VNA, whatever they would normally use as their local contact. And so the question that came up was, for us as a system, was that okay? And at what point did we want to impose a more formal requirement to use some single point of entry when the existing formal networks, the relationship that exists between the VNA and the nursing home is working just fine? That took us to another point in Connecticut to say, how will we help nursing facilities define at what point they need to access the transitional supports versus just use the existing supports that are in place, knowing that we don't have the infrastructure within state government to have everybody go through that single entry point. And in fact, it would slow down the transition work. So that's some of the things that we learned, identifying who gets referred, when they get referred, whether it's going to be a requirement, things you'll have to respond to in your own states before you impose an additional infrastructure over what already exists.
Okay. Ellen?
Yes, Michigan already has, as I mentioned, a robust transition program. In fact, this year we're on track excuse me, to transition 1,500 individuals. And so we kind of had the process in place. And we were surprised at how few referrals we received from this as well. We did over 200 of these and received 9 referrals, only 4 of which were Medicaid. And Michigan has been very involved in working with the Q&A. We use this with the CILs. We provide the Q&A names to the CILs, and we receive data. We have a Q&A resolution form that they submit, and so I ran some of this data just before I came. In fact, I do have a handout out there, and it's probably still warm. But I looked at 2 of the CILs and what we would have received under the 2.0, and the first nursing home, and it's for the same time period. For the first nursing home, we received 2 referrals. We would have received 32 under 12 of which would have been Medicaid under the 2.0. And for the second one, we received 4, and we would have gotten 21 when we ran it using the current method. And the third one, we got 3, but for some reason, their MDS data is lost in cyberspace. So I tried to track that down. They're tracking, my staff is out there tracking it down right now. But, and I looked at what happened with these Q&As. And one of the problems that we found was that many of them had left before we got there, but that was a simple matter of taking the CILs would receive these, because we have a DUA with them, and they would take it to the nursing home and say, who's still here? And so of 308 names for these 2 CILs, 196 had left before they were contacted, and 23 had died before contact was attempted. So that left 89. But out of those, 24 transition cases were opened, or they were referred to another agency, a waiver agent for transition services. 29 chose not to transition. 24 had a decline in health or ability. 10 had DPOA or guardian issues, and 2 went home without agency assistance. But for those, that still is 24 out of 89. And the other thing we found was that there's a lot of value, and I think Mary Merkel alluded to it in the video earlier. She said that she had heard somebody talking to somebody else, And frequently what they do is they pick up the roommate or somebody at their table. But we were just, we were concerned that, and we looked at this to see why there were so few referrals. And it looks like it's because the skip pattern takes so many people out of answering the question. And I had the forms for 157 of the participants. The rest are still in the mail. And when I get back, I'll have the rest of those. But of the 157 participants, only 36 were actually asked the question, do you want to talk to someone about the possibility of returning to the community? Because the skip patterns took everybody else out. But actually 27 of these 36 individuals were incorrectly asked because the skip pattern was not followed. So had the skip pattern been appropriately followed, only 9 participants would have actually been asked whether they wanted to talk to someone about the possibility of leaving. That's like 10%. And so, I mean, what we did was, my staff and I had a meeting just before I got on the plane, and we were talking about, is there a query we could run to capture some of these people like we are getting under the MDS 2.0? And we couldn't find a query that, because would we ask for people where it was feasible? We're not sure. So, but what I think with the discussion today, what we need to look at is what are we getting and what is the, if you will, enforcement, I guess, for them saying, yes, no, they don't have a plan, yes, it's feasible, no, we did not make a referral. And to see what happens with those and make sure those referrals actually do happen, because additional referrals could come from that. And so I think it's just going to take additional work with this and attention to it to make sure, because without that attention, I'm afraid that actually we might lose the resource of the current Q&A, which has been helpful, at least in Michigan.
So I think Ellen raises a good point about the application of this process and how the Section Q is just sort of one tool to be used in identifying candidates for transitioning, and it needs to fit with the existing processes of nursing homes in looking for at discharging individuals. And the skip patterns were really set up to say if a person has a discharge plan already in place, then this question doesn't get triggered because they're already moving in that direction, and maybe you don't need to call in additional resources to supplement that. But I think, as Mary Beth Rebar was saying this morning, part of that's a judgment call, and sometimes you might want to call extra resources even though Q500B isn't triggered by this. It's just sort of common sense application. And so I think some of these things are going to need to be worked out. And fortunately, these states have sort of developed long-standing relationships that are working on these processes already, and this is sort of another tool that's going to be used as part of the process.
May I comment? I mean, you cannot think of this as the only thing for relocation. I mean, this is one of many different activities that goes on, and I think also maybe what's missing in the question queue right now, or which can be incorporated, is the individual has to know that at any time they change their mind, to let the discharge planner know, to know the relocation contractor know, and to ask for relocation activities. That this isn't just going to be, you have this one opportunity, or you have this opportunity once every 3 months. That at any point in time, that you can ask for the relocation support. So the Q, and again, we use the Q1A, we publish it every month. There's only a 17% response rate there. It's just one aspect of relocation.
And I'd like to also add that with the presence in New Jersey, the community choice counselors, they're in the nursing homes all the time doing pre-admission screening and options counseling. And very often the social worker will tell them, okay, you go up and see Mrs. Such and Such. We've had physical therapists approach our staff and refer individuals. We've had roommates refer individuals. So it's not just generated as a result of a question on the MDS.
Oh, you absolutely cannot rely on that, or you're not going to have much of a transition program. But it has been a nice tool that the transition agents have been able to use as an entree into some of the nursing homes. And part of the package that I have out there are a couple letters. 2 of them are signed by our Medicaid director, and one of them was sent to all the nursing home administrators in the state, because there had, in some areas, and this certainly is not all of them, but some of them had been reluctant to let the transition agents in. Some of them had escorted them out. And this is basically to say that they need to work with them. And then there's also a letter that was sent to the SILs and the waiver agents, which are the agencies that house the transition agents. And then there's a letter specific to Q&As. And so it's kind of nice to have that for when you go out if you encounter some resistance. And it's not a hammer or anything. It just basically says that it talks about Olmsted and so on.
Okay, great. Well, maybe the first part of a two-part question, that is, as part of your pilot test process, what did you find that worked well? You want to start with Mark?
Yeah, I mean, having said all that, it is really wonderful to see this Q&A beefed up. I think that is a really important part. And as important as the question itself is, again, it's going to be about sort of a culture change. We use the term person-centered planning a lot with the DD population. We haven't used it as much on the nursing facility side. And so I think culturally we're going to instill the process of a person-centered planning that's an involvement of the individual and more discussion of what they want and what opportunities that they have. So I think that part went really well. They said that it took maybe 10, 15 minutes to actually administer their Q&A, and if anything can start that part of that conversation with the individual and get to know each other more than just the MDS and filling out forms and checkbox, that you're engaged in the conversation, I think that is one of the best things to come out of this, in addition to the more expansive part of the Q&A.
Okay. Mary?
Yes, I have to agree also. There may be individuals that are missed, that this would give them the opportunity to get some more information. And, what worked, we built on an existing infrastructure. It worked very well. We already have good working relationships with most nursing homes. So, we feel like it was successful, and look forward to rolling it out to the rest of the state.
Ellen, what worked well in Michigan?
Yeah, I guess I like the fact that there is a linkage. The last question is that, did you make a referral? And so I think it does create a communication path between the nursing home and the waiver agents and SILs in their region of the state, so they know who they are. And it does build a relationship, and for not only these the Section Q referrals, but for other referrals, because the transition agents do have resources that the nursing homes don't have, and I know that sometimes the nursing homes do want to transition somebody, but there's barriers and they can't address, such as even a ramp. I got a call from U of M rehab center, and he said, can you help us with ramps? Because I can't tell you how many people we have stuck here because they don't have ramps. So we can help with things like that and build those bridges.
Okay. Dawn? Same question.
Yeah, I think that worked well was just the awareness that for the very first time there was an expectation on the institutional side put in place systemically, giving the resident a voice to be able to answer the question for him or herself after admission to the nursing home, would you like to return to the community? And by definition, connecting that voice to the information that might give them the opportunity to create an informed choice. I mean, that is absolutely the best thing about all of this, in addition to being able to provide, to improve our relationships with the nursing facilities. But just a systemic change that might sound like it's not a lot, but it's huge. There are some nursing facilities who don't, well, we have great relationships with most. We do not have great relationships with all. There are some nursing facility administrators who don't see themselves as part of the change. They don't understand the vision. They're not even on the fence. this particular tool in those facilities is going to make, I think, a very big difference, at least saying it's happening. It's going to happen. So.
I guess the other half of that question is what didn't work so well, and maybe what would you do differently? And why don't we start with Mary?
I think what we realize we need to work on is a better way to communicate the outcome of the options counseling. Building on what we already had, we're usually in there doing pre-admission screening primarily for individuals, Medicaid, soon to be Medicaid eligible within 6 months, and the transition information is included in the assessment. So this was new to us to go out and talk to the private pay individuals, although we did on occasion. We never said no to anybody that wanted information. It was outside of the range of what we usually did. So we have to do a better job of communicating the outcomes, following up with those individuals.
What?
Well, what I recognized when I was thinking about being on this panel was we did a great job in my orientation is more Medicaid, although we certainly have Title III dollars we overlook. We're really going to have to reach out to the individuals who are non-Medicaid. We have about $4 million in general revenue that we allocate for the relocation activity. Now, the state of Texas is 1,000 miles by 1,000 miles. For 2 different time zones, we have 1,100 nursing facilities. And that $4 million is supposed to cover, so we already have in our contract, and again, you can read our criteria, we only have the relocation contractors work with individuals with the most complex needs, and we define complex needs along about 9 or 10 different criteria there. So we're going to have to learn and work better with that triaging part. Again, some people aren't going to need the assistance of a relocation specialist. They can provide perhaps just some outreach and education. But we're really going to have to work hard finding either through the ADRCs or through another set of the network, how do we deal with the Medicare population and those on private pay who happen to be in a certified facility and are entitled to the service also. So I think there's going to be a lot more training that's going to be involved, a lot more education, again, through all the various partners, again, managed care, fee-for-service, relocation specialists, all the various different authorities we have in the state, and then how do we start getting the non-Medicaid population invested in the system also.
Okay. Dawn?
There are a lot of things that didn't go all that well during those 2 months. The first question is we're Medicaid agency, and of course a lot of the referrals were Medicare, as Mark was just mentioning. So the question of what do we do with that? Do we spend Medicaid resources if they're Medicare? And that was one question that had to be answered. And will we state fund those coordinators to get, anyway, which we are. We state fund now so to be able to address the needs for those folks who are not Medicaid eligible. There's a state resource. The second one was the confusion on local contact agency. We thought we had communicated very clearly about all this, and we were clearly wrong. So, but that raised the next question. At what point do you refer to this local contact agency that you're going to define as the Medicaid agency, and at what point do you let nursing facilities use those informal connections or formal connections that they already have to the VNA, the home health agency, or whatever? We also had a communication problem. We had nursing facility social workers who had made the referrals to us. We did get 4 in the Medicaid agency. But when the coordinators went out, they didn't announce that they were going out. The nursing facility social workers didn't know that there was no coordination. There wasn't any attempt. And from that, we then developed a couple of tools to require that our local agencies would communicate and evidence that they communicated with the nursing home prior to going out, letting the social worker know, and a challenge checklist, so that that checklist is completed by both our transition coordinator on the Medicaid side and the nursing home social worker, and it creates the kind of foundation for that team process, respecting what the social worker also has to offer in terms of the barriers that they see for that person. So that's the way that we solved the problem, but the problem, once again, was lack of communication. It did not just happen. We needed to create additional structure to help that happen. And then from there came the question of the capacity issue on the local level side. Because if we're going to require, and we did, I think that Mary Beth mentioned, there has to be an expectation for how soon you're going to get somebody out there for that face-to-face. It's one thing to say, contact us. It's another thing to have the capacity to be able to create a reasonable expectation across your own state. And if you have many local level partners, which in Connecticut we have 11 creating a standard process and expectation across all of those so that when we say to nursing facilities, this is what we're going to do, that expectation is actually met on the community side. From that, we actually had to develop a fast track, what we call a fast track mechanism, that gave the coordinators enough information to be able to get out there in an expeditious way. They're required to phone the person within 3 days and be out within 10 days for a face-to-face conversation with the individual, and they're accountable for doing that. But we had to create some structure for them to be able to do it, because if they had a caseload of 25, the first thing they're going to say to us is, we don't have time to do that. So we had to give them, figure out a way for case management that would give them permission to be able to meet the expectation, but also be able to manage the existing caseloads. Those are all things that we had to work through and are in the final stages of right now.
Yeah, we expect, we have a requirement they have to be there within 14 days. And have to make a phone call, again, within that first week for the face-to-face.
Okay. Ellen?
I guess our experience was pretty much the same, particularly with working with the non-Medicaid populations, because both our waiver agents and our SILs we have contracts with them to work with Medicaid, but with one of the requirements being that they be Medicaid. So they had to scramble a bit to come up with resources to share with those who were not Medicaid eligible and were not going to be Medicaid eligible. And that's something we're really going to have to work on as a state and make resources available. Some of them are local, so our local partner is going to have to determine what they have there, but it might be that we're going to have to create a brochure that at the state level that can be shared with the non-Medicaid.
I think, let me speak to California's experience and lessons learned and what they would do differently from the notes Mary Sales sent, and that is the state agency that volunteered to operate the pilot test in California was their health department, which is responsible for nursing home surveying. And the Medicaid agency that's responsible for community-based care programs is an entirely different department. And they usually don't talk to each other. This example, this was probably no exception. They did get together and work to identify volunteer nursing facilities, but sort of the well-established kinds of programs and direction and working with community resources and those kinds of things weren't there. And so I think their big lesson learned was it's important sort of which agency is sort of conducting the program, and CMS is asking Medicaid agencies to sort of take the leadership role in working to designate the local contact agencies, working with developing those collaboration relationships with the nursing facilities, because the Medicaid agencies need to modify their data use agreements, as Melissa was saying, so they have some responsibility in sort of naming the parties in those data use agreements, and so CMS is sort of giving them the leadership role in doing this. So I think the lesson is sort of working collaboratively with all the stakeholders at the table, getting the local agencies to collaborate in that designation process, and sort of get all your ducks lined up. We gave these individuals about 3 to 4 weeks from, hi, I think I'll volunteer to do this, to startup. You all have 6 months. It's a huge, difficult task you're undertaking. So these folks just sort of jumped in and did it fairly quickly. One of the other lessons you've heard a little bit about is training is important. And we gave these folks almost no time to do any training or deliberations or work out the protocols. And fortunately, they were watching and monitoring and listening about the process and said, oh, we need to develop another tool here or another relationship there, or we need to have meetings between the local partners here to sort of cure some of these issues. And I think those are important lessons for all of you that you know about now. You can plan ahead. You can read the information in the interim pilot test report about some of these lessons from these folks, and sort of craft your own paths to putting this together. So if you could join me in thanking the panelists for their courage and hard work.